Well, good morning or good afternoon, everybody, and thanks for logging in today. We have a topic that I've been really excited to hear about. This is Dr. Quin Denfeld, who's joining us from Oregon Health Sciences University, where she's an expert in the relationship of frailty and heart failure. Has done a lot of work over the years, and has was highly recommended by one of our colleagues to give this talk. And I'm really excited to see what she has in store for us. So, Dr. Denfeld, please go ahead and take it away.
Wonderful. Well, thank you so much for the opportunity to present to this esteemed group. It's really an honor to bring to you one area that is near and dear to my heart, frailty and heart failure. Excuse me, I'm still recovering from the cold. So here are the learning objectives for today. For this lecture is to go over the definition of frailty, review the tools available for assessing frailty, and then how frailty influences diagnosis, prognosis, and candidacy for advanced therapies in heart failure. So in order to set the stage for the intersection of heart failure with frailty, I want to talk a little bit about the intersection of aging and heart failure, which lays the foundation for how frailty and heart failure intersect. So I'm probably going to be telling you a lot of what you already know, but I want to just give this as a foundation. So we have two issues when it comes to the relationship between heart failure and aging. The first is the aging of the population, as we all know. So the total size of the older adult population is increasing. By 2050, 1 in 5 people in the US will be 65 years of age or older. So that's going to just naturally translate to more heart failure hospitalizations, an uptick in the mortality rates with heart failure. So just overall heart failure is going to increase in prevalence as a result of aging. The second problem is that the condition of heart failure often accelerates what's called biological aging. So we have our natural aging process that we can't stop for lack of trying, not for lack of trying, but we have this natural aging process, but then heart failure itself and likely other comorbidities can contribute to accelerated biological aging across multiple physiologic systems, like the sympathetic nervous system, like increased inflammation. And these processes can operate independent of chronological age, as many of you can imagine patients whose chronological age does not match the phenotype of their biological age. So taken together, this is going to increase what's phenotypically observed as geriatric conditions like frailty, cognitive dysfunction, and fall rates. So let's talk about what frailty is. So frailty, the word itself, derives from the Latin word fragilis, which means easily broken. Frailty was first conceptualized by researchers in the geriatric world. Of course, frailty had been used colloquially across many different situations, clinical practice and non-clinical practice. But what it actually meant and what the definition was not really solidified until our geriatric colleagues took the lead in coming up with a definition. So the definition that I use, which is typically used in some form or fashion throughout the literature, is that frailty is defined as a decreased reserve and resistance to stressors resulting from cumulative declines across multiple physiological systems and causing vulnerability to adverse outcomes. So taking that definition and then operationalizing it is what's really has been very difficult. So again, thanks to colleagues in our geriatric world, they've come up with multiple definition or multiple assessment tools, which I'll talk about in a little bit, to assess what frailty. So before that, people typically eyeballed a patient or shook their hand to determine what frailty was. Prior to learning about what frailty was, whenever anyone mentioned what frailty or asked me about frailty, I pictured my grandfather, who's pictured up here, who was in the years leading up to his death from cancer, was someone who was largely confined to a chair or a bed, unable to do the physical activity they wanted, very tired. So taking the definition and putting it into an assessment tool was quite difficult, but Fried and colleagues really led the way. Rockwood is another key leader in this field, but the definition that I use and the assessment tool I use is the frailty phenotype criteria. So I'm going to walk you through this cycle of frailty that was put forward to describe what frailty is. So there's an entry point into the cycle of frailty, which is usually some combination of aging and or disease. Then you have loss of muscle mass, you have weakness and fatigue, you have slowness, You have decreased physical activity, and then that will compound weight loss and poor nutrition, and then that will, that will further lead to loss of muscle mass, and you can imagine the vicious cycle that ensues. So all of this taken together was then what formed the basis for the assessment of frailty. So now bringing in heart failure. So in terms of the intersection of these two conditions, there's two things that have firmly been established. So first, the prevalence of frailty and heart failure had been estimated to be high, but where was the estimate? What was the actual estimate of frailty in this population? So when I started diving into this literature circa 2012, what I was seeing was that the prevalence of frailty ranged widely from about 15% to upwards of 90%. So in order to ascertain where we stood in terms of the prevalence of frailty and heart failure, we conducted a meta-analysis that was then subsequently published in 2017. And based on 26 studies that measured some form of frailty, let's see here, make sure this goes forward. Whether that was multidimensional frailty or physical frailty, we generated an estimate of the prevalence of frailty and heart failure and determined that about 45% of patients, or about 1 out of every 2 patients with heart failure, is likely considered frail. So about 50%, if that's an easier number to remember. So comparing that with the estimated prevalence of frailty among the oldest old, so just looking at community dwelling older adults over 90 years of age, that estimate is about 20 to 25%, or 1 out of every 4. So it's pretty profound that the prevalence of frailty and heart failure is so significantly high. The second thing we've established in this field is that frailty is clearly associated with worse outcomes. And this is based on multiple meta-analyses, 2 of which are up here. So on the left-hand side is a forest plot of the effect size of the relationship between frailty and mortality. And what this showed was that across 29 studies, frailty confers about a 48% increased risk of mortality and heart failure. And then another meta-analysis by Dr. Eric Fung's group reported a 1.5-fold increase in the adverse outcome of death or instant hospitalization associated with frailty. So it was similar results, and this has been shown across multiple other studies. On the patient-reported outcome side of things, there's fewer studies that have looked at this, but this is one area that I've been working on leading and paving this road. So frailty confers worse symptoms. We showed that frailty confers worse dyspnea, sleep problems, and depressive symptoms. We've also shown that those who are frail have significantly worse quality of life, especially physical quality of life. So establishing the clear link between frailty and outcomes has really launched this field and focused our attention on understanding how, why, when, and for whom frailty affects people with heart failure. So another thing I want to mention that needs to be out there alongside the prevalence discussion is that when I started working on a study of gender differences or sex differences in frailty and heart failure, which I'll show you on the next slide, I also wanted to see, are there actually gender sex differences in the prevalence of frailty and heart failure? So I worked with Dr. Mary Roberts Davis, who was a grad student at the time, and we conducted another meta-analysis, which was a follow-up to our previous one. We pulled all the studies that up to that point, which is 2021 or 2020, I think is when we stopped doing our review. But we pulled studies that reported some prevalence of frailty that was separated by women versus men. And we found that overall, women had a significantly higher risk of being frail compared with men. In fact, in putting a number to this, women had about a 2% absolute higher risk of being frail compared with men. So that was really profound to see that. And then in our study that we ran, one in which it was our main focus to see, are women truly, in fact, more likely to be frail compared with men? And the rationale for doing this study came from the broader gerontological literature, in which they had shown that women were significantly more likely to be frail compared with men, the male-female health survival paradox. And so we found in our sex balance study, it was a smaller study of 115 patients with heart failure. Women were still significantly more likely to be frail compared with men, kind of full stop. And examining the individual frailty criteria, which I'll go through what those are in just a moment, we found that significantly more women than men met 4 out of 5 of the physical frailty criteria: weakness, slowness, physical exhaustion, and low physical activity. Okay, so we see that women are more likely to be frail, but then what about all the other factors that could contribute? So in our multivariate logistic regression model, we found that women had over 4 times greater odds to be physically frail compared with men after adjusting for other comorbidity or other covariates like body mass index, type 2 diabetes, etc. So this again was really profound to see that in a sex balance study, women were significantly more likely to be frail compared with men. Okay, so what's causing the frailty? That's a big question. That is really it's a very nascent field. A lot of the mechanistic hypotheses are still in that hypothesis stage. Because there's significant overlap between the mechanisms of frailty and heart failure, it's really difficult to tease apart which comes first, the heart failure or the frailty, kind of a chicken or egg situation. So in this study, which was part of that study of 115 patients with heart failure, we collected samples, fasting blood samples from them. And I wanted to look at targeted biomarkers to see, can we tease apart what's going on with frailty, looking at some targeted biomarkers that cover different pathophysiological processes across the board, things like NT-proBNP and ST2, or sorry, not ST2 for this one, but NT-proBNP, sympathetic activation with norepinephrine, insulin resistance, inflammation, adipose tissue dysfunction, skeletal muscle dysfunction, and catabolism. So after running these biomarkers and comparing them and adjusting for other covariates, we found that those who were physically frail had significantly lower IGF-1, lower adiponectin, and lower myostatin, indicating that frailty in heart failure is linked with some degree of catabolism, adipose tissue dysfunction, and skeletal muscle dysfunction. And then in just an exploratory sex stratified analysis, I want to point out that only IGF-1 and myostatin were significantly associated with frailty in men, but not in women. So that's launched another aspect of my program of research to understand why that is. All right, let's move on to the assessment of frailty in heart failure. So the field has established that frailty is prevalent, prognostically significant. There's some key sex differences in frailty and heart failure, but one looming question is, how do you assess it? And so I've already talked about how the gerontological literature has moved this forward with multiple different assessments. Moving this into heart failure has been difficult, and I have to say that there is no consensus across the board, but we are moving forward and at least putting it out there that a couple of key messages. And one is that the eyeball assessment and the end of the bed assessment are out. Don't do that. The handshake test, probably not reliable. It might help a little bit, but multiple studies have looked at subjective clinician estimated frailty and found that it's not a reliable replacement for formal frailty assessments in heart failure. So even though people still may use these, really doing a formal assessment, even if it is just a smaller assessment of frailty, is better than just eyeballing a patient. Okay, so if those are out, then what is in? So with over 60 available assessments, how do we pick out of those? So I just kind of want to give you a brief kind of overview that the assessment tools generally fall into a physical frailty assessment tool, which is largely led by the frailty phenotype criteria, and then the multidimensional assessment tools, which is largely led by the frailty index, which focuses on deficit accumulation frailty. So there's multiple versions of those that have spawned off of those kind of two camps, but these ones are generally the ones that are out there and validated and well used. And so this is a really good starting point for assessing frailty. Then there's other things that we can consider, whether there's those screening tools or related domains, which I'll talk about in a little bit. But how to land on an exact assessment of frailty has been a topic of conversation for many, many years. Here's two papers that are up here. Dr. Shirley Z did an analysis looking at different assessment tools and screening tools of frailty, specifically in heart failure. And these are the Venn diagrams that are shown up here from that paper. And then Dr. Jonathan Afalalo wrote a nice editorial about measuring frailty as well. So I just want to talk a little bit about how we assess physical frailty. This in my graduate school dissertation phase, focusing on how to measure frailty and heart failure for our research studies. So we use again, the frailty phenotype criteria, these 5 criteria. I'll walk you through each of these. So we assess shrinking with a question about unintentional weight loss of 10 pounds or greater over the past year. The key word is unintentional. We want to focus on people who are really losing weight, but not because of fluid shifts or not because they're trying to lose weight intentionally. We assess weakness with both grip strength and 5 repeat chair stands. So grip strength is what the original frailty phenotype criteria used. But by the recommendation of an exercise physiologist, we added in 5 repeat chair stands because they assess lower extremity function and they better replicate a function that patients with heart failure, or all people for that matter, perform every day, which is just getting up out of a chair, getting up off a toilet, etc. And we found that the chair stands are more informative. So we use those for our assessment of weakness. Slowness is with an assessment of gait speed. We ask them to walk over 6 meters and timing them over 4. We have a questionnaire about physical exhaustion, and we ask them about physical activity. Then in order to calculate it, it's pretty straightforward. If they meet 3 or more of these criteria, they're considered physically frail. If they meet 1 or 2, they're considered pre-frail. If they don't meet any, they're considered non-frail. So the majority of the patients that I've assessed over our years of doing studies are either in the pre-frail or physically frail categories. Less than 10% tend to be in the robust category. So the approach to assessing frailty has, again, not been standardized, but we've really tried to move this forward just to at least bring it on people's radar. And so I had the privilege of leading this consensus statement commissioned by the ISHLT, along with many esteemed colleagues across the world, to just move this stagnant area forward. Even if there's still many unanswered questions, we need to bring more of this research to practice now that we know that frailty intersects with heart failure quite a bit. So I'd like to acknowledge my co-leads on this, Dr. Sunita Jha, Joanne Lindenfeld, and Peter McDonald, who really helped in this Herculean effort to move this statement forward. And this was published in January 2024 in Journal of Heart and Lung Transplantation. So to set the stage for part of this, I'm going to walk you through this statement with a few different figures. So first, we wanted to emphasize just the challenges of ascertaining frailty in heart failure, because patients may not exactly exhibit the traditional quote unquote form of frailty that's commonly pictured, like that which was experienced by my grandfather on one of the first slides. So here are 2 example phenotypes of frailty in heart failure. So on the left, you have an older woman who's non-ischemic etiology due to hypertension. She has heart failure or HFrEF. She's really tiny, only 118 pounds. She has AFib in addition to having heart failure. When she was assessed for frailty, she met 3 out of 5 of the criteria, so she was considered frail. So what is her frailty due to? Is it due to age, heart failure, her one comorbidity of AFib? We don't know, but it's probably some combination therein. On the other hand, on the right side, you have a young man who also has non-ischemic heart failure, but that's due to past drug use, also has HFrEF. He's morbidly obese, but without many other comorbidities. He also meets 3 out of 5 of the criteria, albeit different ones. So his frailty may be due to heart failure and obesity. He might have some sarcopenic obesity, perhaps. So both of these patients are considered frail, but then how we approach frailty in these patients can be different, and it can be really challenging to discern how we want to manage frailty in 2 patients who are both considered frail, but could be frail for wildly different reasons. Another challenge with frailty and heart failure is, again, distinguishing frailty from different domains and related concepts. So again, this is another point of discussion, and another unanswered question out there in the field is how do we approach frailty when it's related so closely to other concepts like sarcopenia, other domains like cognitive dysfunction, psychological problems like depressive symptoms, malnutrition. So where do we draw that conceptual line around frailty? Does it only include physical performance measures, like primarily the physical frailty criteria, the frailty phenotype criteria, that is, or do we add in closely related domains? And then I think it makes it even more difficult because a lot of these overlap with heart failure. So how do we disentangle all of these? We do know that if you add them all together, they can be multiplicative in predicting adverse outcomes. But adding in everything, as one of my colleagues said, adding in everything but the kitchen sink can also be a lot. So based on the evidence to date, we recognize that there's a lot of different domains surrounding frailty. But because of the evidence to date that we reviewed, we moved forward at least the physical aspects of frailty as a starting point for patients with heart failure, but then with the suggestion to add in additional domains as needed. So here's one of the tables from our paper. And one of the and these are our recommendations that we put forward in the paper. And our first recommendation is that a frailty assessment should be performed in all patients with advanced heart failure, especially those undergoing LVAD implantation or heart transplantation. So I think frailty should be assessed in all patients with heart failure, but especially the patients with advanced heart failure. And as a starting point, again, based off the literature out there, we suggest that patients we suggested a modified version of the frailty phenotype criteria for patients, and then with considerations for other additional assessments. So using those 5 criteria that I talked about a little bit earlier, we recommended, based off the literature, a combination of these different assessment tools to assess frailty. So one thing I want to point out is that the loss of the shrinking criteria, that is, which is really trying to capture that loss of muscle mass. It's really can be really difficult, as you can imagine, in patients with heart failure in which weight is wildly changing. So one question we added in to better replicate or probably better tap into that loss of muscle mass is a question about appetite. So we inserted 3 questions for loss of appetite, or excuse me, loss of muscle mass or shrinking, physical exhaustion, and low physical activity. These are based off of the SHARE F5 scale, which is a scale used in primary care to assess frailty. And then for weakness and slowness, we really felt like the evidence was strongly in support of doing an assessment of weakness and slowness using physical performance criteria. So weakness with chair stands, and then slowness with gait speed. So just simply watching a patient walk, watching them get up out of a chair can be really informative in ascertaining their level of frailty. And then the scoring is very similar to what I talked about earlier. 0 criteria, they're non-frail, 1 to 2, they're pre-frail, and 3 plus, they're frail. But then again, we wanted to put out there that there's additional assessments to consider that can overlap with frailty that can be multiplicative in predicting adverse outcomes. So looking at things like cognitive dysfunction and depressive symptoms is highly encouraged. We also wanted to recognize the importance and the potential role of the frailty index, that is the deficit related index, which is in short, it accumulates all of the different deficits that people can have across multiple physiological systems. This is one put forward by Rockwood and colleagues. And this is one that might be particularly helpful as a screening approach in large data sets or in medical records. So I just want to recognize that one as well. So the management of frailty in heart failure. So I won't have a lot to say on this because we actually don't have a lot of evidence to support what we do to manage frailty. But I have a few key points that I want to bring forward. So there's 2 perspectives to consider when we try to manage frailty and heart failure, just given that both of these together can be a really complex clinical picture. So one perspective is, how do you manage frailty in a patient who has heart failure? So you're trying to manage the frailty with things like exercise, nutrition, just drawing from the broader frailty literature. Or are you trying to manage frailty who just also, or excuse me, or are you trying to manage heart failure in the patient who also has frailty? Are you trying to figure out how to take care of this patient with heart failure when they're already looking really frail? They score highly on the frailty criteria. How do you implement GDMT, decision-making around advanced therapies? So again, there's not a lot of literature to say exactly how we do this, but in my opinion, it's probably not an either or, but a both. We have to consider both approaches, and definitely more evidence is needed. So one way to approach the management of frailty that I want to put out there, this is one that I've carried through for many years, is to think through what are the potential causes of frailty and heart failure. Is the frailty, going back to those pictures of the woman and the man who are both frail, is their frailty cardiovascular related or non-cardiovascular related? So this is a figure from Dr. Kelsey Flint and colleagues that was published in 2012. And I love this because it really kind of encapsulates all the things that kind of underlie that frailty phenotype. And in this paper, they used LVAD responsive versus LVAD independent frailty to indicate what might be responsive to LVAD specifically. But I think we can extrapolate that and expand it out to other heart failure therapies. So is the frailty going to be responsive to to GDMT or advanced heart failure therapies? Or is the frailty going to be responsive more to things that are kind of more generally frailty related or addressing the comorbidities that come with heart failure? So just a few key studies to give you a sense of how frailty may be mitigated with some of these therapies. This is a paper by Dr. Peter McDonald's group. They did a systematic review to see how frailty improves with specific therapies. There's much more to this paper than this particular table, but I want to point this out that they reviewed the literature on how frailty changes after LVAD and transplantation and concluded that frailty improves for some patients after LVAD, but most of the improvement we see is around by 3 months. And then for transplantation, frailty does seem to improve. And in fact, one study that was led by Dr. Sunita Jha found that there was 13 patients who were frail right before they underwent heart transplantation. And when at follow-up, none of those were frail. So heart transplantation may really significantly improve frailty, but it's still to be determined. The rehab heart failure trial was really helpful in kind of giving us some other tools to help frailty. This was specific to older adults who were hospitalized with heart failure. This was a transitional tailored progressive rehabilitation intervention that included 4 physical function domains. They found that after 3 months, the intervention group had significantly greater improvement in the short physical performance battery score than the control group. So positive trial in that regard. But one thing I want to point out is a secondary analysis that was led by Ambarish Pandey that looked at those who were frail at baseline. Did they also show improvement? And what was interesting was that those patients who had worse baseline frailty status had actually a greater significant improvement in physical function in response to the intervention than those who were pre-frail. So frailty may in fact be an effect modifier, and frail patients may still benefit. So we don't need to exclude those patients from this intervention. And then lastly, managing heart failure in the patient who is also considered frail. So there's a couple of studies out there that have looked at the relationship between frailty and GDMT. Here's 2 examples up here. Quin and colleagues using a trial data set found that patients with HFrEF and a higher burden of frailty were less likely to be initiated on GDMT. Kondo and colleagues also found that. But interestingly, patients who are frail, if they do get started on GDMT, do benefit and may, in fact, have a greater benefit than those who are non-frail. So just because a patient is frail doesn't necessarily mean we don't escalate them on GDMT. And then frailty also is important to think about in terms of decision-making. So frailty in and of itself is not a contraindication to things like LVAD or transplantation. And in fact, frailty may be reversed. So I want to point out that frailty is not a contraindication, but just a consideration. So going back to our 2 patients who both are frail, but could be frail for different reasons, which group are they going to be in? So this is the bottom half of that figure by Dr. Kelsey Flint and colleagues. So if we put in an LVAD, for example, or if we do some other kind of intervention, how much are we going to shrink frailty? We don't know. So we which group would they be in? It's hard to say, but we definitely need more evidence to support helping these patients who are frail, who have worse outcomes, especially patient-reported outcomes. How can we mitigate frailty with our toolbox of interventions? And this is my one more slide, and then I'll wrap it up here. But I want to point out this really excellent review by Dr. Kenneth Rockwood, who is the architect of the Frailty Index, and Dr. Kim, who just kind of summarized the state of the science of frailty broadly in older adults. But this figure is really helpful, I think, to understand what do we do with our patients who are fit or pre-frail or frail or have end-stage frailty, recognizing that most of our patients with heart failure are going to be on that far right side with the frail or end-stage frailty. So here across, what are the goals? What are the lifestyles, disease management, interventions, patient engagement, social support? So you can see that there's actually a lot of common threads across all of this that we might want to think about for our patients with heart failure. And then I want to point out one bullet point that was really that stood out to me was that frailty assessment should be used not as a convenient way to withhold potentially effective treatments, but rather as a tool to facilitate patient-centered care. So that's one note I want to leave you with. These are my take-home points: that frailty is common, especially among women, associated with poor outcomes. Strongly recommend assessing frailty in the patient with heart failure, but causes are multifactorial, so we have to think about through all of those. And that frailty and heart failure should probably be co-managed, considering the bidirectional relationship, but just use it as a point to, for patient-centered care. And I just want to thank my funders and my lab team members for all their support, and I will turn it back to Dr. Beasley.
Well, thanks so much, Dr. Denfeld, for that really great talk. Um, it's amazing the amount of science that exists in this space, and really so much that you presented that, I completely was not aware of before your talk. So I learned a lot from what you have presented. Does anybody who's still on the call have any questions for Dr. Denfeld that they'd like to ask at this moment? I think one of the things I was going to ask you about, it's kind of a twofold question, is that you made mention about women having be more likely to be frail compared to men. We know that women, especially approaching the later decades of life, appear to be more likely to develop heart failure and heart failure with preserved ejection fraction. And in contrast to heart failure with reduced ejection fraction, a heart failure with preserved ejection fraction isn't something where we get typically insurance coverage for things like cardiac rehabilitation. That might be really helpful in somebody who's frail. So I don't know if you have any recommendations for exercise prescription or other types of ways to kind of help manage someone's frailty if they are in that situation where um, I guess funding hasn't quite, or reimbursement hasn't quite caught up to where we are and what we know is needed from the population that we serve.
Mhm. Yeah, that's a great question. And if I could tackle that question with my program of research, I would retire as a happy person. But yes, I think yeah, I probably won't be able to tackle the reimbursement side of things, but I do think we need to start creating some evidence base around reimbursement for some of these other non-pharmacological therapies that particularly impact patients who we don't have a lot of tools for. And I think the rehab heart failure is a really important step in that direction. You know, they have a follow-up trial that focuses specifically on HFpEF patients. And so I do kind of feel like, going to the sex differences in the women especially, they might be like doubly disadvantaged because they're not only older and they have more comorbidities, they have HFpEF, and there's other things that there's not as many tools. The number of tools to help these patients, at least from a reimbursement standpoint, are dwindled down. So what do we do with these patients? So I worked with an exercise physiologist. She does exercise trials with cancer survivors, but one of her main messages is that exercise is medicine. We have to start prescribing exercise for these patients. And that's one thing that would be wonderful to move in that direction. I'm looking forward to seeing how Dr. Kitzman's trial pans out with the rehab HFpEF. But starting to create the evidence base of these other therapies and tools that we can use to help these patients, who kind of, again, that older woman who has HFpEF, how do we help her? So it's great. That's a great question.
It's a lot of comments in the chat praising you for your work and your talk. So, well, thank you so much,
I have a
Dr.
question.
Denfeld. Oh yes, go quite ahead.
All right. Yeah, thank you very much, Dr. Gaffey, for that wonderful presentation. I learned a lot. So my
Mhm.
question is about regarding the weakness in as part of the relative phenotype. The for people who cannot, for one reason or the other, do the use the chair to sit up and down for multiple issues like the back pain and other things, can hand grip be a surrogate form of evaluation on probably using a dynamometer? Can that suffice, for that, just doing a hand grip? And how would we evaluate hand grip if we use that for the reason that they can't sit or stand on a chair because of other orthopedic limitations?
Mhm. Oh, I love this question. Yes. So, yeah, just asking somebody to get up out of a chair 5 times can be hard for some people who have back pain, who have arthritis in their knees. So it might not be because of the heart failure, it might be because of something else. So kind of a few thoughts on this is one, that if they still aren't able to do it just because of something else like orthopedic or musculoskeletal, I consider that as part of the whole picture. So even though the heart failure is probably not causing that problem, it's still limiting their ability to get up out of a chair. So that might be somebody who has more of those non-cardiovascular causes of that. And we have to think through things that might help the orthopedic musculoskeletal problems. But as you mentioned, grip strength might be a great substitute. So that's why I like doing both of those. If you have a dynamometer and you can get some grip strength, that does help. And this has really been helpful for patients who just are like either wheelchair bound or they're confined to the bed. We can at least get an assessment of it. Are they probably going to also be weak? That's likely. If you're weak by chair stands, you're also likely weak by grip strength, but not always. So I think just capturing some kind of data of weakness, however you can, is going to be really helpful. And then if you're going to be managing that patient, like understanding why that patient isn't able to get up out of the chair, or they're not able to do that grip strength, can be really informative to help us understand how to help them with mobility, how to help them with physical activity. But yes, if you can do grip strength for that patient, please do that as well.
Thank you very much.
All right. Well, I know folks have to get back to clinical work now. Past the top of the hour. So, Dr. Denfeld, again, thanks so much for your talk and presentation, and thanks for everybody for joining us this afternoon or morning, depending on where you're at. A question about where can we get the recorded videos? They are available on YouTube. And let me find. I will stop the recording now, and then I'll put that in the chat for you, so that